Again, I want to implore you to fill out the evaluations. It's very important for us to know how this is for you and what suggestions you have to improve it, what things you'd like us to do differently, what ideas you have for our future summits. For those of you, as you get back and you talk to people about the summit and they express either their regrets that they weren't able to attend or weren't invited, please let them know that we have video recorded the entire summit. There'll be the first presentation will be on my blog Tuesday, and then we're going through the editing and packaging process. We will catalog these in individual sessions so that somebody can go and pick a particular session to review without having to start and try to go through the entire film. So that will be coming, so look for that. What I'm going to do is in 5 minutes summarize really what we've talked about during these 2 days and especially today. Our mission is to improve the health of the people of the region we serve. In the past, we have been appropriately focused on improving the health of sick and injured people. After attending this for 2 days, hopefully what you understand is we really have to be about the health of the people that we serve, and it's a much broader undertaking than just waiting for them to get sick or injured and then try to improve their health. It's not just sick care, it's improving health. As Bob Locken referred to it, it's being proactive instead of reactive. And it's the only way, population health management, it's the only way that we're going to truly be successful in achieving the third aim of our triple aim, and that is to lower costs. And it's going to have to come from, partly, from keeping people from becoming patients, because it's just too expensive once you become a patient. It's going to have to come from reducing irrational variation, and that is what we're going to attack through lean, our teamwork approach, evidence-based medicine, eliminating waste. That's what we've got to focus on. It's going to come from reducing low-value and no-value services, which account for at least 30% of the healthcare spending. And it's going to come, most importantly, and this is what we need the network to do, to align the incentives across the network. Problem is, we operate in a world today where all the incentives are haywire, and we work at cross purposes to each other. So we got to align those incentives, and ultimately, it means, as Dr. Warner was pointing out, taking the performance risk for the network. That's where we've got to go. In order to manage risk, there's lots to do. One is we've got to have more parts and pieces of the delivery system coming together in Select Medical Network so that we truly can coordinate all that care. But they can't continue to operate as pieces. The fragmentation of our healthcare delivery system is incredibly inefficient, promotes waste, and does oftentimes result in less than optimal outcomes. And so we have to have integration, or as Bob referred to, an aligned system, where people really are talking to each other, as you heard Dave Behunin talking about yesterday, the integrated records, sharing data, working together, all the things that go into clinical integration. And we have to have the data analytics to identify what the opportunities are and to continue to drive improvement, as you heard Dr. Brian Fortuin explain. We've got to continue with our clinical integration initiatives, as Dr. Coates talked about, and pushing those things that we're working together on to achieve this performance. And then finally, I think you've got to think about those 4 groups of patients that we talked about in population health management. Those that are currently healthy and really are, and we just need consumer engagement tools like Beth Gray was talking about, and how we're going to keep them healthy. Then we've got the second group who are healthy today, but maybe they're smokers, maybe they've got high cholesterol, whatever, maybe they have a genetic predisposition, but we know with time, they're going to be a patient. And we've got to employ risk mitigation strategies. And then the third group, those that are what we take care of today, people that end up in our doctor's offices and our hospitals, they're acutely ill. We have to treat them. We have to do so at the best possible quality, hoping to have zero harm, as Dr. Priest talked about and Dr. Hill talked about, that we don't do something to harm them and that we return them back to whatever state they were. And then the fourth group, that small group, but as you saw from the white cloud evidence and you heard Dr. Nash and Dr. Warner talk about, that small group of chronically ill patients, but they consume a disproportionate amount of the healthcare spending. We've got to coordinate their care better, like you heard Dr. Nekachia talk about. And we've got to manage care transitions when they leave our hospitals and go to post-acute care settings, like you heard Dr. Kadian talk about. And, you know, John Miller really asked, as he always does, you know, the really, really uncomfortable question about, you know, how we're really going to transform and transition from fee-for-service to pay-for-value, and realizing that we're going to be in both worlds for a long time. But how do we do that? And I'll just add my own thoughts that I think it's not going to change the way Dr. Fortuin treats patients, whether they're in a value-based contract or fee-for-service. He's still going to treat their heart failure the same way. He's still going to treat their diabetes the same way. But all these other programs that we're developing to really manage the care, and we get beyond that 15% of the healthcare determinants, the things that we're doing that are additive programs, that are resource intensive, and we don't get compensated for under fee-for-service, those programs are going to have to be directed to the patients that are in our value-based contracts. And if we think that we really believe what we've been talking about, that that is a better way to manage patients, and in fact it will lower costs, what that means is that with those payers that engage with us on this, they will be able to offer lower premiums. Lower premiums mean they attract more patients, so that's got to be the motivation for payers to want to evolve with us as we develop the competency and can demonstrate to them that we can manage the health of a population. So I want to say that while all of this, if you're not overwhelmed, you haven't been paying attention for the last 2 days. You should be overwhelmed. We're all overwhelmed, but that doesn't mean we don't get focused and do this in incremental steps. We have to be about it. It's a multi-year process. We'll never really be done evolving, but it's going to take us a while to do this, but we have to make steps. And as you heard Dr. Nash say, we've already made a lot of steps. We're out further than a lot of health systems that he's seen across the country. So yes, it's okay to be a little overwhelmed, but what I tell all of our employees and our leadership is stay focused on your why. Why is it worth going to all this trouble? Why is it worth taking 2 days to meet here? Why is it worth running this executive team nuts with all kinds we just got so many things going on? Why is it worth it? Why do we work this hard? It's because we know the system is broken. We know that our families, our neighbors, and ultimately us are going to need these services. We better design it the way it's supposed to because we can't count on the government or somebody else to do it. We are Idaho's hope. We have to do this, and we have to do this for our grandkids. Jeff Taylor showed his granddaughter up there. That's why we got to do this. Because if we don't fix this, then when she grows up and becomes in need of services, she's going to be experiencing all the problems our patients are currently experiencing, and we can't let that happen.